You're listening to Medscape's In Discussion series on chronic obstructive pulmonary disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Leah Witt. Dr. Witt is a geriatrician and pulmonologist at the University of California, San Francisco. At UCSF, she is also the Pulmonary Associate Chief for Ambulatory Affairs, a coach for the Pulmonary and Critical Care Medicine Fellowship, and a passionate advocate for improving the care of older adults with chronic lung disease. Dr. Witt is an associate editor, producer, and sometimes co-host with The Curbsiders, a popular internal medicine podcast where she's covered topics on chronic lung disease, geriatrics, and gender equity. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Leah Witt. Welcome back to Season 1 of the Medscape in Discussion COPD podcast series. Today, we're talking about palliative care and symptom management in COPD, and I'm delighted to welcome today's expert guest, Dr. Anand Iyer. Dr. Iyer is a pulmonary critical care physician scientist and associate professor in the Division of Pulmonary Allergy Critical Care Medicine, the Division of Gerontology, Geriatrics, and Palliative Care, and the School of Nursing at the University of Alabama at Birmingham. He's also a physician investigator in the Geriatrics Research and Education Clinical Center at the Birmingham Veterans Affairs Medical Center, and is UAB's first recipient of a Beeson Award, supported by a Paul B. Beeson Emerging Leaders Career Development Award in Aging from the National Institute on Aging. His research and advocacy focuses on developing innovative solutions to help patients and their families living with serious respiratory illnesses to improve their well-being and maintain independence in their communities. And he's also a wonderful person and a dear friend. So welcome to the Medscape in Discussion podcast, Anand.
Thank you for having me, Liam. It's an honor and it's going to be fun to be here.
Yeah, so we like to start these episodes by talking about what's on your mind outside of medicine, hobby, book. For me, it's usually Netflix. What's on your mind?
Right now, I am slightly nervous to make sure that my daughter's doing well in her fiddle competition. So not to push the Alabama stereotype, but my half Indian daughter has picked up fiddle in addition to classical violin. And since I can play guitar and play piano, I'm usually her accompanist. Next week, she's doing her spring recital, and I have a piano piece to play with her and a guitar accompaniment to make sure that I have ironed out before in a week. So I got to work on those things, but it's super fun and like a high priority for me. So I love it.
Yeah, such a fun father-daughter thing to do. Very cultured.
We stand out in the crowd. That's for sure.
Like usual, the thing that is on my mind is much less cultured. I've been binging the Last Dance documentary on Netflix. I recently texted one of my residency group chats and I said, have you guys seen this? And they were like, yeah, it came out like 4 years ago during the pandemic.
Yeah, for sure.
Yeah. I was like, wow.
I binged that one.
Yeah, really good. Lots of MJ content. And I'm also reading the pieces talking about how he influenced the commentary, but you know, there are opinions on both sides. So
that's so good. I love that you're an NBA fan.
All right. Well, let's start talking COPD. Today, we're going to keep talking about Mr. Rivera. He's a 78-year-old man with COPD, and we're talking to you about palliative care and symptom management. He's got group E COPD, so he really has a lot of symptoms and frequent exacerbations. He's actually, in the last year, progressed quite a bit and has been hospitalized 4 times, including 2 ICU stays, and he's had to use BiPAP. His FEV1 has dropped quite a bit. It's now 0.6 liters. And he comes to clinic to see you today with severe shortness of breath and cough, but he's also mentioning that he's feeling really depressed and lonely, and he hasn't been able to do his usual social activities, which are getting together to play cards with his friends. So I wanted to start by asking you how you approach a patient like this with high symptoms and exacerbations in your palliative approach.
The way you described him, I'm only thinking first off, I wish I met him a year ago. And the things that we could have done to help him improve his well-being, his function, his independence by thinking of things holistically and comprehensively could have made a huge difference, I think, in his trajectory and his just overall well-being. And a lot of people will put him into sort of this bucket of end-stage COPD. Oh, there's not much I can do. Thinking of things with a palliative approach gives me the ability to say, what else can we do? And there are so many things. I immediately start thinking about treatable things that are in that list of sort of symptoms you described, putting them into categories like I taught my resident on Tuesday. What are the symptoms that are most worrisome to him? And what are the things that we can do that are both pulmonary, but then non-pulmonary? So we can pick apart any one of those symptoms, but I imagine he's super breathless, if you want to talk about that one to start.
Yeah, let's start there. Let's talk about breathlessness, especially beyond like inhalers and the adjunctive medications that we've talked about before. Like, I mean, we can talk about that too, as roflumilast, but what are you thinking with his breathlessness?
Right. So that is one of the most distressing symptoms. And if you put that on par with lung cancer or heart failure or something, people with COPD who experience refractory breathlessness is a horrific experience that they describe as drowning, and it causes them to not go back in their communities, and they can maybe even be breathless while going across the room to the bathroom. So I'd really want to understand how bad this is for him, what are its triggers, and what he does to sort of bring that breathlessness down. Let's make sure absolutely everything is optimized. Let's make sure he knows his inhalers. He might have nebulizers available. He might have a BiPAP at home. And then, okay, these are pulmonary things. Have we ironed out all of those? Does he have comorbid heart failure or heart disease or pulmonary hypertension or something? Okay, cool. Like that's 101. Let's get all that checked out. And then we start this sort of palliative level care. We will start to think, okay, measuring the breathlessness more accurately, using symptom measures. Does he have action plans? Does he know how to do pursed lip breathing and diaphragmatic breathing? How well does he remember his exercises from pulmonary rehab? And has he still practiced those things? What kind of home exercises can he get? And then can I get him in conjunction with my palliative care clinicians on possibly doing some low-dose opioids for this refractory breathlessness in a safe manner that both of us feel comfortable about? And that's how I would start right there and see.
So you mentioned an action plan, and I think I know what you're talking about with the ATS, acute breathlessness crisis. Is that what you're referring to, or
something? Yeah, those kinds of things, right?
Yeah. So what does an action plan look like?
Right. So they're variable, but there are some from American Thoracic Society. There's COPD Foundation has some. These are crisis action plans that sort of say, in the event that you're having sort of acute breathlessness, that you're not feeling like you can stop, what are some ways that you can bring this down? Imagining a quiet place, thinking about the beach, sitting down, using pursed lip breathing, engage your diaphragm, and then at last resort, have you reached for your inhaler and then your nebulizer, and if things aren't still improving, then you call. But those, printing something like that out in clinic, handing it to him, and walking through those steps, of which I just did on Tuesday in my clinic with somebody, it was remarkable how they had no idea about any of them. And these are possibly the triggers that are bringing him in for these frequent exacerbations. That could be one way to reduce those if he has something like this at home, and available low-dose opioids if he needed it in those events to safely treat that severe shortness of breath.
Mm-hmm. Okay, so you started to talk about low-dose opioids. When do you think about opioids with severe breathlessness? And then do you have any general framework for where you start or how you think about approaching it?
Yeah, I think from what I've learned from my palliative care colleagues and the way the system is set up, a lot of pulmonologists are afraid to start them, and the research isn't exactly solid. So I'll lay it out there. Safety exists, and in people with COPD, you're worried about respiratory depression or hypercapnia. So most people don't want that to happen and cause worsening hypercapnia. So that is a huge barrier. I often will let my palliative care colleagues say, I'm okay with this. This person's referred to you. Let's work together and find a safe medium. And then I can take back over once you sort of started and titrated. And oftentimes it's something low, morphine that's low dose, that's long acting, that will last a lot longer. And so they figure out a dose that's safe and helps the patient feel better. And this has happened at least 5 times in the last year for me, that they've expressed immense benefit from having this available to them in these sort of severe, very severe airflow obstruction population with refractory breathlessness, team-based, safe, and everybody feels better about it, including the patient and their families. So that's just one way to look at it.
It sounds like you're thinking about a referral to palliative care if that's available where you are, but maybe earlier in the disease course. When do you think about referring, and how do you talk to a patient about that referral?
Yeah, this is the thing we've tried to push. We recently released an ATS policy statement that talks about palliative care early in the continuum. I think the best thing to let the audience to this podcast know about is all hospice is palliative care, but not all palliative care is hospice.
Oh, I love that.
People have learned about palliative care because it was born of the hospice movement, and therefore, yes, that's true. And it is a benefit for the last 6 months of life when someone's nearing that end of life care to progress towards death and to bereavement. That's hospice. Unfortunately, that has extended and continued to think that I'm trying to make everybody go towards hospice, when in fact I'm not. Because if you look at it, palliative care is a comprehensive discipline for emotional, physical symptom support, caregiver support across the continuum to relieve suffering in a patient with serious illness. So none of that said because they're dying and they're at the last week of life. Unfortunately, all we do is refer to them in the ICU when they're on the vent and we need help getting them off the ventilator, or they only have 3 months to live and we need to get them to hospice. I would love to start the discussion a year in advance, and this gentleman would have been somebody last year I would have already referred because he met so many criteria that we set aside in that ATS policy statement, and we use something called the Leber's model. There are domains like lung function, breathlessness, oxygen, exacerbations, comorbid needs, caregiver needs, whatever. And each one of those rises up to a certain threshold where you need to start engaging a palliative care approach by yourself as a clinician, as a pulmonary person or primary care doctor, or it's really high. There's severe breathlessness. I would go ahead and get palliative care on board as a team, as a specialty referral or secondary palliative care. So I would have started an approach in my own clinic that would have looked at all these things last year, measured the symptoms, started the education, began the early discussions about what this thing could look like in the next year or two, and then slowly started to feed in. But there's this team that can help me, help you with symptom management. Let's start getting them involved. I think that's important.
I think what you said is right. A lot of people understand palliative care as it relates to hospice. So I feel like I have a challenge when I talk to patients because they think I'm saying something that I'm not, which is that they're at the end of their life. Do you have a way that you describe it to patients?
This Mr. Rivera is 78, but the last 3 people that I've referred to palliative care have been like younger people. And so wait, what? You're referring those people to palliative care? Absolutely. Because their anxiety is quite high. Their symptom burden is quite high. And because of the way I've engaged that team early, all of us are happy. The patient's happier. Her well-being is so much better. She hasn't been to the hospital but once in the last year because of all these things. So I describe it as a team of clinicians from multiple disciplines, both physicians, nurse practitioners, who have so many resources at their disposal available to help you feel better and improve your well-being. That's it. I didn't even say the H word in this discussion. I'm getting them here for these 3 things. Your anxiety is too hard for me to manage. I don't know what to do as a pulmonologist. Your breathlessness is at the limit of what I can do, and I need them to help me start some sort of regimen of low-dose opioids and adjacent medications that will help us feel safe, and then help me help the team collaborative care about goals of care and advanced care planning. To them, I'm like, this is just a team. They're called palliative. It means to cloak as in a serious illness. They're just going to help us, help me, help you. It takes a couple of visits, but then they're like, oh, this is awesome.
Yes. Okay. I love that. So this patient has been to the hospital 4 times, and this might be also a good time to talk about what the future looks like. What would you want if you get readmitted? How are you talking about advanced care planning, expected management, things like that?
Yeah, that's the great question. People may not realize that each exacerbation is like a sentinel event in COPD, especially if it's severe. not only is his functional status declining after that and not coming back, his well-being is going down, his risk for future exacerbations is going up, his mortality is through the roof. So 1 in 4 may die in that year, and 1 in 2 might die in 4 or 5 years. So that just by itself. Now he's at 4. So his survival is just very low, just from the exacerbation number.
One of our previous guests called an exacerbation a lung attack, like a heart attack, which I thought was a great way to discuss it.
Yeah, that's great. And they take major hits to lung function and well-being. So he's at 4. So that is already portends a low survival. I would already calculate a BODE score, so BMI, obstruction, dyspnea, and exercise capacity, and I would put that in the calculator and I'd get some points for, okay, he probably can't walk very far. His breathlessness is really high, but it's like a 4 on the MMRC scale. He has probably terrible airflow obstruction, so that's also high. And then I don't know if he's cachectic and frail, but he might have a really low BMI as well. All of which just say his mortality is really high. It could be, I'm just looking it up, it could be his survival could be like 18% or 15%.
In 3 years, right?
Yeah, in like the next 3 years or so. And so that's a BODE score of 7 to 10, and it's 3 years. What ways can I nudge that BODE score to be a little bit lower for him so that I can extend his survival? Well, I could maybe get him to palliative care to improve nutrition counseling so that his cachexia is a little bit better and he puts on a little bit more muscle mass. He's in pulmonary rehab again. So that's 1 point better. I've improved his refractory breathlessness. He can walk further now and his exercise capacity is better. So that's 2 or 3 points better there. And then his breathlessness is down. That's another couple of points. So I started trying to tackle some of those points on the BODE scale. And already I've gone from, I think, 18% to the next category in BODE is in the 50%. So we've gone from like a survival of 18% to a survival of 50% by just decreasing those categories and shifting those by 1 or 2 points each. So I think of ways that I like to talk about. We could tackle each one of those using a palliative approach or even using the team from palliative care to help me do that. And I've already made a tremendous improvement in his BODE score. But like, those are people that it's so tough because there's so many we see, you and I see in clinic that have in quote unquote end stage COPD, living with an FEV1 of 20 for 10 years. I don't know what to do. It doesn't, that's like a lot of people.
That was actually going to be my next question, because I think this conversation about prognostication is so important. And a lot of people want to hear from me. You know, my friend has cancer. They told them they have this much time left. So how much time do I have left? And our prognostic scores, that BODE score, is 3 years, that's a hard one to wrap your mind around.
Correct.
And when we're saying we can refer to hospice when the prognosis is less than 6 months, we don't have a great 6-month prognosis calculator for COPD, and people can live for years and years with terrible lung function. So how do you talk about prognosis and decide when to refer to hospice?
It's planting the seed kind of stuff, and it's layered earlier conversations that evolve as the disease progresses. So if I had seen Mr. Rivera last year, I would have said, hey, look, I don't know what the future holds. I put some numbers in and it's not looking great for the next 3 to 4 years. But as he got exacerbated, he came back to me in another big clinic visit. I said, oh, that's another one. That's taken a big hit on you. Oh, you've had another. And so we would have had this conversation change and evolve over time. So that's the first thing. It doesn't have to be set in stone. And he'd meet a lot of criteria to go to hospice, and it's okay to come back out of hospice. So it's not like he goes there, he gets a lot of home benefits. He gets a lot of home health in the house. He gets whatever resources that the benefit can provide for his home living situation. And so more power to them, I guess, to get a lot of those resources that they would otherwise not have had. And maybe his quality of life is better. And I've had at least a couple in the last couple of years come back out. And I am better. I've gone to exercise. I've done my things and now I'm getting better. So sure, that's great. So prognosis is murky in COPD. It's not as clear cut as like idiopathic pulmonary fibrosis or lung cancer who have more defined trajectories. I will say with medications, IPF is now looking a little bit more like COPD, but it's not so precipitous decline COPD is chronic slow decline over time. And that makes it hard. I think it's just telling patients you don't know and you're okay with not knowing. But there are things that appear in this stage. Exacerbations, shortness of breath, those kinds of things.
Yeah, and I think because the prognosis isn't as straightforward as things like lung cancer or IPF, that's why these patients don't get referred. They're definitely under-referred to palliative care and hospice. So that it's at the front of your mind. I like that a lot. And then that is why that long-term relationship is so important. So every visit is another conversation about where you are and what progress has been made in either direction.
Correct. And some factors to me will jump out like a cachexia, like a super frail person, like a high exacerbation or refractory breathlessness. Those are the domains I'm talking about that really raise red flags to me that something's not going to go well in the next year or two. And it's just that simple. It's not, you're going to get an exacerbation. No, it's just going to be tough. And here's some things you might experience. You may not be able to get to the mailbox in 6 months. We're going to try to help you through that, but just keep that in mind. Like, they don't know that. They don't know because there's not that honesty up front. So from our experience, years and minds, we've seen that happen. And that sort of poor functional status just keeps getting worse. And so they need to kind of know what that might be like so they're not afraid, but we can put into place some things to help them avoid that.
Well, I wanted to spend the last few minutes talking about the social symptoms he mentioned and mood symptoms. So he mentioned he's feeling depressed, he's lonely, he's not able to do his social activities. Until some of the important research that you and your colleagues have done, this didn't maybe rise to the minds of pulmonologists as like, this is in my domain. But tell us a little bit about the work and research you've done about these social symptoms and COPD.
We've been working in the space of emotional symptoms in COPD for some time, looking at sort of frequency of anxiety and depression in COPD as high as 1 in 3. The numbers are quite variable just by the way you measure them, but at least a third of patients with COPD have anxiety and depression. It could be much higher. And then of those who have anxiety and depression, about half don't even have any sort of medication or therapy for their anxiety and depression, oftentimes chalked up to COPD itself rather than a functional emotional condition that needs its own treatment. And it's usually black males that go untreated. So there's some sort of stoicism there that also we found in recent papers. And then as your gold letter groupings get higher, your anxiety and depression symptoms go up and your untreated anxiety and depression go up. And then that predicts future exacerbations independently. So that's anxiety and depression. And it's a big beast of a challenge by itself. Now we've signed, and I'll give a shout out to Angela Soon from UCSF. We all did work together on what are the prevalence of social isolation and loneliness in people living with COPD in a large cohort. And I think it's 1 in 6 have social isolation and 1 in 5 experience loneliness. And then what's frightening is that once they start using oxygen, it doubles. And so it's oftentimes that they have twice that social isolation and loneliness as those who are to the general older adult population. And we hear this all the time. That tank is too heavy for me. I can't move it around. And then now all of a sudden what's supposed to help them is now a barrier to getting out of the house, and they can't move and they can't go anywhere. You're just thinking about trying to tote a big tank and a walker and get out and go to church. Like, that's not that easy to do. And yet we're trying to get it because it's a mortality benefit in a certain subset in COPD for getting on oxygen and severe hypoxemia. But now it's trapped them and increased their risk of social isolation and loneliness. So to me, that's a big, important trade-off that we need to have as a culture and as a medical community. Are we doing the right thing, and why do we have more portable options? But that's a whole nother discussion. So.
I agree with you. We could do a whole other episode on this, and I appreciate the work you're doing to bring these social and mood symptoms into the domain of pulmonologists, because it really affects how people take care of themselves and ultimately their disease trajectory. So I wanted to wrap up and ask, what few key points do you want to make sure that the listeners leave this episode with?
A couple of things. I like the statement I made that all hospice is palliative care, but not all palliative care is hospice. Think about this discipline and this integration early. Pulmonary clinicians and primary care can start thinking comprehensively about a disease or chronic disease on their own. That's primary palliative care. but don't hesitate to reach out to your colleagues at your institutions to start the referral process early for whatever it might be, anxiety, breathlessness, depression, social isolation, caregiver needs, whatever. As long as they start doing this proactively, I think their well-being can improve and their independence can improve. And I've seen that firsthand from my patients.
Thank you so much for joining us. So I'll just wrap up and say that today we've talked to Dr. Anand Iyer about palliative care. This was an amazing episode, and we could do 3 more on the same topic. Thank you so much for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on COPD. This is Dr. Leah Witt for the Medscape in Discussion Chronic Obstructive Pulmonary Disease podcast.
Thanks for listening to Medscape's In Discussion Chronic Obstructive Pulmonary Disease podcast series with our host, Dr. Leah Witt. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on chronic obstructive pulmonary disease.